Assalamu alaikum. It's Psychiatry CMS from Solve part. Now, I would like to discuss about the Psychiatry CMS form Solve. Hope you enjoyed. Start with my intro. Can you hear this murmur? Okay, tell me in the comment box. Okay, start with this. This 6-year-old boy is brought to the physician by his parents. He has a problem in the bed waiting 5 times weekly, and most of the accident occur in the first 3 hours of the night, occasionally during dreams in which he imagines himself urinating. He imagines himself urinating. So he does not go to the sleepover to the other friends. Why it happens? He has a type 1 diabetes mellitus. Was diagnosed with type 1 diabetes mellitus. So what does he have? This is primary anaerosis. Why it is not urinary out um, overflow incontinence? Urinary overflow incontinence, secondary to DM, most commonly occurs in patients experiencing polyuria related to poor blood glucose control. These patients' type 1 diabetes mellitus is well controlled with insulin. So the last option remains primary anaerosis. Primary anaerosis refers to the episodic urinary incontinence occurring in children older than 5 years. Occurring in children older than 5 years, the episodes are commonly lead to adjustment problems, low self-esteem, low self-esteem. The pathogenesis of the pathogenesis of primary anaerosis. The pathogenesis of primary anaerosis most commonly involves delay in the maturation, though it may be alternatively related to small functional bladder capacity or genetic disorder. Along with the voiding diarrhea, this is important. Along with voiding diarrhea, patients with nocturnal anorexia should undergo through a history, physical examination, urine analysis to rule out the medical causes like bladder dysfunction, urinary tract infection, bladder dysfunction, urinary tract dysfunction. Many patients with primary aneurysms spontaneously improve through motivational therapy, rewarding the patient, rewarding the patient for urinating to. Okay, so let's move on to the next question. Okay, Alzheimer disease looks like older patient Alzheimer disease acetylcholine is so dementia Alzheimer type results in decreased cholinergic signaling. Cholinergic neurons which primarily originate from the cholinergic neuron which primarily originates from the locus ceruleus. This is very high yield word. Cholinergic neuron arise from locus ceruleus and the basal forebrain. A project so cholinergic neuron which primarily originate from locus ceruleus and focal and basal forebrain. And GABA primary neuroinhibitor central nervous system, not for dementia or Alzheimer type. And dopamine is in the mesolimbic pathway, and dopamine is related to movement problem. Glutamate is exists or leads to neuronal excitotoxicity. Okay, next question. Um, okay. Uh, so this 72-year-old man, Parkinson's disease. is brought to the physician by his wife for follow-up of 6 weeks after Pramipexole added a regimen levodopa to manage for severe bradykinesia. We know that Pramipexole increases the dopamine concentration in several brain areas. In the dorsal stratum, increased dopamine concentration leads to improvement in Parkinsonism. In ventral stratum, dopamine enhancing medication may lead to mood dysregulation or depression. Commonly manifestation with somatic or neurovegetative symptoms in the limbic system. In the limbic system, an increased dopamine concentration leads to in limbic system an increased dopamine concentration can lead to psychotic symptoms such as paranoid delusion, hallucination, and incongruent effect demonstrated by this patient. Distressing psychotic symptoms in the setting of the Parkinson disease. Treatment are typically managed with antipsychotic medication or decreased dose of inciting medication. So this patient has insisted uh, that Prowler or Paramore was sneaking around the house. He intended to be decreased appetite. He has hypertension control, blood pressure normal. Examination show less rigidity, increased arm swing. With examination show he's cooperative and superficially polite, but he problem in here that this patient become increasingly suspicious of her and has accused her of infidelity. After adding the pramipexole, this new paranoid delusion and psychotic symptom happens. So this is due to adverse effect of the pramipexole. It's not delusional disorder because by the presence of one or more delusion, fixed false belief for a month or longer without other psychotic symptoms. This patient does not demonstrate one circumscribed delusion, instead presenting with against his wife, general paranoia against his wife, her paramour or prowler. Further, the onset of psychotic symptoms correlates with the initiation of the pramipexole. Okay, next, this patient, schizophrenia is characterized by delusion, hallucination, disorganized speech. Treatment require long-term antipsychotic medication in patients with partial response to an antipsychotic. A dose increase should be considered. A dose increase should be considered. However, intolerable side effect may limit the maximum acceptable dose. Quetiapine, atypical antipsychotic medication that primarily antagonize the dopamine receptor and serotonin receptors. Quetiapine antagonize histamine receptor, adrenal receptor, muscarinic receptor, leading to sedation, weight gain, orthostatic hypotension, and anticholinergic side effect. An anticholinergic side effect, dry mouth, inner retention, constipation. This patient experiencing the combination of intolerable sedation leading to non-adherence and incomplete control of psychotic symptom. Incomplete control of psychotic symptom should be trialed on a less sedating antipsychotic medication. Aripiprazole lower affinity of the histamine and acetylcholine receptor factor and therefore less likely cause sedation. So these patients' mental status show agitated mood, guarded effect. So agitated mood, guarded effect. These are the features. These are the features. That's why we are changing quetiapine to aripiprazole because these quetiapine has antagonized histamine receptor, adrenaline receptor, muscarinic receptor, leading to sedation, weight gain, and orthostatic hypotension. It leads to sedation, weight gain, and orthostatic hypotension. Aripiprazole has less antihistaminergic and acetylcholine receptor. That's why this is the answer. Why this is adverse effect of the hydrochlorothiazide. Electrolyte derangement such as hyponatremia can cause altered mental status. And hyponatremia can be acute or chronic. Acute hyponatremia occurs 24 to 48 hours, commonly presents with symptoms of nausea, malaise, lethargy, obtundation. Nausea, malaise, lethargy, obtundation, or coma, and seizure secondary to cerebral edema. Secondary to cerebral edema, as water is drawn into neuronal cell in the setting of hypotonic interstitial fluid. Given the rapid decline in sodium, symptoms can even present with sodium concentration of less than 130. In chronic hyponatremia, however, symptoms generally do not present until hyponatremia has become significant. Sometimes include fatigue, nausea, forgetfulness, lethargy, confusion. Hydrochlorothiazide and other thiazide diuretics can induce hyponatremia because of impaired urine dilation. Because of impaired urine dilution, since they act on sodium chloride symporter, in the distal tubule, they do not affect the medullary gradient or the action of the ADH. Therefore, these patients can lose sodium in excess of water, leading to euvolemia, but also hypovolemic hyponatremia. The loss of excess solute in relation to loss of water also explains this patient's hypokalemia and hypochloremia. Treatment of diuretic-induced hyponatremia involves discontinuing the causative agent, restoring euvolemia if the patient is not euvolemic, and restricting free water intake. Premenstrual dysphoric disorder. In premenstrual dysphoric disorder consists of affective and somatic symptoms occurring in the week before menses. According to DSM-5, patients must demonstrate at least 5 symptoms. The symptoms must include at least one mood symptom: affective lability, marked irritability, depressed mood, anxiety, and at least one of the following symptoms: anhedonia, concentration difficulty, decreased energy, hypersomnia, insomnia, an increased or decreased appetite, a sense of being overwhelmed, a sense of being overwhelmed, and physical symptoms days after means onset and resolve during the week after means the diagnosis is established by the patient's prospective documentation of symptoms in relation to at least two menstrual cycles. The pathogenesis is likely related to modulation of neurotransmitters such as serotonin secondary to changes in estrogen and progesterone concentration. SSRI are indicated in patients with moderate to severe premenstrual dysphoric disorder, whereas patients with mild premenstrual dysphoric disorder may benefit from counseling about stress reduction and lifestyle changes. Okay, next, this is the Korsakoff psychosis. So, 48-year-old man is brought to the emergency department. Mm, he is alcoholic and some sort of psychosis. Patients who chronically abuse alcohol typically demonstrate a significant thiamine deficiency caused by poor nutritional intake, thiamine malabsorption, and impaired cellular utilization of the thiamine. Over time, thiamine deficiency can result in damage and atrophy of the mammillary body visible on MRI of the brain, which manifests Wernicke encephalopathy. The typical presentation of Wernicke encephalopathy triad: altered mental status, ophthalmoplegia, and ataxia. The symptoms of Wernicke encephalopathy are reversible, but increased risk of developing Wernicke-Korsakoff syndrome, also called Korsakoff psychosis, in chronic alcohol user if not immediately treated with high dose in chronic alcoholic disorder if not treated with high dose thiamine. Wernicke-Korsakoff syndrome is an irreversible condition. Wernicke-Korsakoff syndrome is an irreversible condition that features an anterograde and retrograde amnesia, along with the consequent tendency to confabulate or verbalize false stories or memories to compensate for the inability to remember. The patient demonstrates inability to form new memories after the amnesia causing event. Okay, next. So it's Williams syndrome. In Williams syndrome, there shows a small upturned nose, small chin, long philtrum, and muscle tone is decreased. In Williams syndrome results from sporadic inherited deletion of contiguous genes on chromosome 7q1123, including the elastin gene. Patients typically present with overly friendly demeanor, emotional dysregulation, intellectual delay, elfin faces like strabismus, flat nasal bridges, short nose, long philtrum, wide mouth, short stature, vascular and cardiac valve abnormality, and secondary to lasting dysfunction. Structural abnormality of the urinary tract and endocrine abnormality, hypothyroidism, Diagnosis confirmed by genetic testing or deletion of the 7q, this and that. Okay, Cornelia de Lange syndrome. Cornelia de Lange syndrome. Sporadic deletion of cohesion complex gene. Cohesion complex gene. There is intellectual disability, facial dysmorphia, and malformation. Okay, option 9. 77-year-old woman come to the physician at the request of attorney putting. She says that she wants to have an advanced directive in order to avoid putting an unnecessary burden on her children. She wants an advanced directive. She demonstrates she understands the meaning of standardized story. Which of the following is the so though some cognitive impaired patients may lack capacity to make decisions about their care, cognitively impaired patients should not be assumed to lack of decisional capacity. Though this patient illustrates mild abnormalities on brief cognitive testing, which may indicate normal aging change in a patient with limited education, these findings do not necessarily preclude her for making end of life decision. To, to meet the criteria for decisional capacity, patient must express a consistent choice, demonstrate and understanding the risks and benefits of her choice, demonstrate an appreciation of the significance of the choice of her personal circumstances, and illustrate an ability to reason through the option. Therefore, to assess this patient's decisional capacity and potentially write her advance directive, the physician should discuss the patient's preference for care and for assess the four decisional capacity criteria. Okay, so option 10 is caffeine withdrawal. I got this right, and this is RLS, restless leg syndrome, pramipexole, and ropinirole. Um, this is MS, multiple sclerosis, because MR of the brain shows mm, numerous small plaques in the periventricular white areas. Okay, this is bipolar disorder. How I diagnose this as a bipolar disorder? Features of acute mania. This is the high yield. He talks rapidly and abruptly, shifts from topic to topic. This is the features of mania. And where there is mania, there is bipolar. Okay, why it is metoprolol? Cocaine. Cocaine is an addictive recreational drug that cause euphoria, restlessness, increased sympathetic tone, tachycardia, hypertension, pupillary dilatation, Cocaine blocks the presynaptic reuptake of norepinephrine and serotonin and dopamine, which increases the concentration of this substance, in the synaptic cleft. The increased norepinephrine causes tachycardia and hypertension through activation of sympathetic adrenoreceptor, leading to increased cardiac chronotropy and peripheral vasoconstriction. It can cause coronary artery vasospasm. It can cause coronary artery vasospasm, which presents with chest pain and new ECG changes, T wave inversion, ST elevation, or depression. Beta blocker therapy is in cocaine intoxication can lead to unopposed alpha-1 adrenergic activation, which can lead to marked hypertension and further increases the risk of coronary vasospasm. Therefore, inpatient beta blocker monotherapy with metoprolol would be contraindicated. Which of the following drug is contraindicated this patient? This is a very interesting question. This is a very, what can I say? This is a very high yield question. This is a high yield topic. So, beta blocker therapy in cocaine intoxication can lead to unopposed alpha-1 adrenergic activation, which can lead to marked unopposed alpha-1 adrenergic activation, which can lead to marked hypertension and further increases the risk of coronary artery vasospasm. Therefore, in patients with administering beta blocker monotherapy with metoprolol would be contraindicated. Cocaine is a sympathetic medication that leads to increasing cardiac tomography and peripheral vasoconstriction. It can cause coronary artery vasospasm with significant myocardial ischemia. Beta blocker monotherapy is contraindicated in patients who use cocaine as it can lead to unopposed alpha-1 adrenergic activation, which presents with marked hypertension and further increases the risk of coronary artery disease. Okay, I got wrong. Why I don't know. I failed to diagnose the OCD, which I am master in OCD. Okay, so this 37-year-old woman comes to the physician because of 4-month history of recurrent thoughts that she has that she has sexually mm, abused her 5-year older daughter. She says that she examines her daughter's perineum several times daily looking for evidence of abuse. Examination of the child by the pediatrician show no evidence. Examination of the child. This is very high yield. I don't know why I made this. I I do not go through the whole question, so I do not get the scenario sometimes. Even though I know the answer, but sometimes I do not get the answer as because I I go through a fast pace. That's why my brain does not catch the actual answers. Okay, not to worry. It's a process. It's a way of looking at the patient. Okay. So examination of the child by her pediatrician. So 4-month history of recurrent thoughts that she has sexually abused her 5-year-old daughter. But she says that she examines her daughter's perineum several times daily looking for evidence of abuse. Examination of the child by her pediatrician has no evidence of abuse. The patient believes that she is going crazy. She reports that she was sexually abused as a child. Physical examination shows no abnormality. On mental status examination, she appears tense, anxious, and mildly depressed. She cries as she describes her worrisome thoughts. There is no evidence of hallucination. Which of the following is the most likely diagnosis? A 6-year-old boy is brought to the physician for world child examination. His mother states that he has had increasingly impulsive behavior, aggressive outbursts during the. So this patient has ADHD with chronic symptoms of hyperactivity, impulsivity, inattention for more than one setting, and impaired academic, social, emotional functioning. Child with predominant hyperactivity symptoms are often unable to sit still and may have difficulty turns, may have difficulty turns. So stimulants into amphetamine and methylphenidate are the first line drug for treatment to increase dopamine, increase synaptic dopamine and norepinephrine. So behavioral rating scale by teacher. It's toluene. Why it's toluene? So inhaled gas, a problem in the CT scan. The patient fall asleep for an hour. The second neurological examination on awakening show full alertness and normal gait. So this 15-year-old was brought to the emergency department by paramedics 30 minutes after 30 minutes after uh, he noticed after his patient noticed that he had become very confused and unsteady. His friends reported that he may have been trying to get high. He may have been trying to get high. Glucose analogs and administered en route emergency department produced no change in the condition. His lethargic naloxone for alcohol, and if the other urine toxicology screen are pending, second neurological examination show full alertness and a normal. Inhale abuse toluene nitric oxide spray paint. Toluene nitric or nitrous oxide spray paint and glue is common in patients with children and adolescents. The effects typically begin seconds of use and persist for approximately 30 minutes, representing a faster onset and resolution compared with other recreational drug. Inhalant exerts multiple organ system dermatological perioral or perinasal dermatitis or erythroderma or pyoderma, otolaryngologic line nosebleed. So severe inhalant toxicity can manifest with tachycardia and mere respiratory depression, this and that. So it's toluene. Prevention is the key. To schools should monitor the use of solvent-based products. Parents and should be educated. I don't know why I choose bulimia nervosa. It's anorexia nervosa. BMI is less than BMI is slightly low. And intense fear of self-worth. BMI is less than 70. Though patients with mild anorexia they can demonstrate greater than 17. Like if there is mild, so they can demonstrate these 18. And there are other features of anorexia nervosa. Amenorrhea is the common and reflects insufficient nutrition. Reflects insufficient. Alternately, patients with bulimia do not demonstrate severe malnutrition that leads to amenorrhea. So amenorrhea is common and reflects insufficient nutrition. Look at this point. She has not had a menstrual period for 6 months. So amenorrhea looks like anorexia, but because in bulimia nervosa typically do not have severe malnutrition that leads to amenorrhea and low BMI, and other features of bulimia like purging, knuck, scar on the knuckle, erosion of enamel, these features are not present. Okay, it's parenting classes. Normal 4-year-old children play with other children. Play, make believe, tell story, understand time and counting, and stand and hop on one side of the foot and cut their own food with supervision. Typically, preschool children also demonstrate defiant behavior and picky eater. When children demonstrate difficult behavior, patients should utilize ignoring and other patterning skills. Teenage patients commonly possess inadequately parenting skills may increase their attention to the child and during tantrums, reinforcing the tantrum behavior. Symptoms of MDD includes um, this patient disrupt everyday functioning. This patient disrupt. He cannot remember. Um, These patient symptoms disrupt everyday functioning. In patients with MDD, atypical feature neurovegetative symptoms typically manifest as hypersomnia and hyperphagia. Patients with MDD with atypical features may also patients with MDD. Symptoms of major depressive disorder includes 2 or more symptoms, at least 5 of the following symptoms. In patients with MDD with atypical feature, neurovegetative symptom typically manifests as hypersomnia, hyperphagia. Patients with MDD typical features demonstrate improvement in mood, oversensitivity to interpersonal rejection, latent paralysis, heavy sensation in the extremities, leading to extreme psychomotor retardation. The underlying pathogenesis is believed to arise from personality and temperament characteristics that promote emotional and behavioral dysregulation in response to stressful situations such as interpersonal rejection. This patient's subjective memory loss and severe psychomotor retardation that improve as she develops rapport with the physician. Neurologic disorder. When this patient fear or of interpersonal rejection by physician decreases, her distress and consequent psychological need to convert her distress into neurologic symptom dissipates. So treatment of atypical depressive disorder involve antidepressant and medication and psychotherapy. Okay, so measurement of electrolyte concentration looks like bulimia nervosa, and in bulimia nervosa, uh, there is vomiting. So hypokalemia is common. Increased bicarbonate concentration leads to renal potassium exchange and consequently. Okay, next, why it is quit pain. Bipolar disorder. So flight attendant report the patient should he was the pilot and didn't fly by the time. So dig first and dig first, decrease need for sleep, increase goal directed activity and rapid speech or thinking, irresponsibility as evidenced by the patient's uh, demands to fly the plane and grandiose thinking. Some patients demonstrate associated psychotic symptom, grandiose delusion, hallucination. Management of acute mania requires motor stabilizing therapy, mood stabilizer, or mood stabilizing antipsychotic. Atypical antipsychotic olanzapine, which antagonize the dopamine receptor and modulate serotonin activity, possesses mod possesses stabilizing properties and demonstrate effectiveness for acute mania over a course of days. Acute mania over course of days. Alternatively, for acute bipolar depression, the most effective medication, the most effective medication and choices are lurasidone, quetiapine, lamotrigine, and fluoxetine and olanzapine. Once acute mood episodes resolve, patients with bipolar disorder should continue the mood stabilizer to prevent future event of mania or depression. Acute mania is typically manifest with irritable. Some patients associated with psychotic symptoms like grandiose delusion, hallucination, Management of acute mania requires mood stabilizing therapy. Atypical antipsychotic which antagonize the dopamine receptor and modulate certain activity possess mood stabilizing property and demonstrate effectiveness for acute mania for over a course of days. Alternatively, for acute bipolar depression, the most effective medication choice is lurasidone, quetiapine, lamotrigine. So, acute mania typically manifests with irritable euphoric mood, increase the energy, a decreased need for sleep, yes, management requires stabilizer or antipsychotic causes the mood stabilizing. Okay, schizophrenia. So this 20-year-old man emergency by her parents. He has not moved and spoken for 60 minutes despite encouragement. He has similar episode over about 6 months. Her parents said that he had always been shy and loner. He has not looked for a job. He has not looked for a job since graduating from high school 2 years ago. He appears unkempt and long fine nails. Is also Catalonia neurobehavioral symptom marked by inability to move or snake, inability to move or snake, or speaking repeatedly that arises in exacerbation of the psychiatric symptoms such as bipolar, schizophrenia patients with stupors, patients with stupors. Mm, okay, catatonia is a neurobehavioral syndrome marked by inability to move or speak, by the ability to speak to stop moving or speaking repetitively. Okay, it's adjustment disorder refers to an emotional disturbance. Emotional disturbance within 3 months of an identifiable mental disturbance within 3 months of an identifiable stressor. The emotional disturbing manifests as marked distress, hmm, out of proportion to the stressor and a significant impairment in daily school work or social functioning. Patients may internalize or externalize their the emotional marked patient may internalize or externalize their distress resulting in depression. I don't know why I am unable to figure out this shit. I have problem in diagnosing it. I have problem in diagnosing the adjustment disorder. I have diagnosing plenty of things. Is an emotional within 3 months of identifiable stressor. The emotional disturbance manifests as marked distress out of proportion to the stressor and a significant impairment in daily school, work, social functioning. Patient may internalize or externalize their distress, resulting in depression or anxiety symptoms, conduct disturbance, and respectively. Patients with adjustment disorder do not meet the criteria of anxiety depression and conduct disorder. This patient has anxiety, the depression syndrome, difficulty concentrating or sleeping. As adjustment disorder, it is self-limited trait. Okay, so we have behavioral OCD. OCD is on drugs, so he needs behavioral therapy only. It's bupropion weight loss. So we tried. Where is the weight? Okay. Persistent depressive disorder, also known as thymic disorder, very, very, very high. Hmm. So this patient, why were using thyroid patient, difficulty falling asleep for 3 years. She reports more difficulty falling asleep for 3 years. 5 weeks ago, her cat recent changes in the weight and the appetite. She worked a registered nurse on the overnight shift. She does not enjoy her job even though she is expected. Examination, physical examination shows no other abnormalities. On mental status examination, she is pleasant and polite. She says she felt sad when her cat died. So said no other abnormality. So if the depression is more than 2 years, at least 2 years depressed mode, patient on this normal behavior, patient expectation exerts strong influence on children's well-being, unrealistically high expectation, unrealistically high explanation can lead to child's feelings disappointed and inadequate. These feelings may be internalized, lead to depression or externalized acting out, such as slamming the door. So emotional dysregulation may be acting out, slamming on the door, externalization, acting in leads to depression. Okay, this one is very important. Okay, adverse effect of the haloperidol. NMS developing malignant syndrome, evidence and design. Okay, it's message and adjustment disorder. I got another adjustment disorder wrong. Okay, adjustment disorder. request acidity to calm her nerves, calm her nerves. Like adjustment disorder is one of refers to emotional disturbance. Adjustment disorder, emotional disorder, 3 months of an ideal with the emotional disturbance presence. Patients internalize the distress. Patients that do not meet the criteria of anxiety, depressive, and conduct symptoms. This patient has some anxiety, some depression symptoms with a clear stressor without meeting the criteria anxiety or disorder. So adjustment disorder is typically self-limited. Treatment is adjustment disorder most commonly include um, psychotic brief, psychotherapy brief, psychotherapy. Okay, so it's a brief psychotic. The patient meets the criteria of acute onset, one or more psychotic symptom, delusion, hallucination, desires, disorganized behavior, less than 1 month. The patient is experiencing a paranoid delusion, behavior, speech, auditory hallucination. This factor of psychotic less than 1 month include stressful life events, personal disability, or hospitalization, and antipsychotic. So brief psychotic disorder characterized by onset of one or more psychotic symptoms lasting less than 1 month. This patient has delusion, hallucination, disorganized speech, very high health, fetal alcohol syndrome, upper limb, neuropil trauma. It's acute stress disorder. An acute stress disorder, intrusive thought, memory, arousal, reactivity, that can occur within 1 month of traumatic event. The inciting traumatic event. Mm, Specific phobia, Romero, arbitrary benzodiazepine are the permitting the increased influx of the chloride ions and decreased neuronal activity in brain regions for possible such for fear such as amygdala. Okay, recommendation to distinguish marijuana use. Cannabis can lead to erectile dysfunction. slow oxidating, obsessive compulsive disorder, fluoxetine, so patients usual methadone is an opioid which can be used in treat pain. And methadone is commonly used on the daily. Uh, okay. Mm, Decline in working memory, schizophrenic form, must demonstrate probable cognitive training, postulate the excessive part in glutamatergic synapse. Mm, mm, So compared to other recreational cannabis has long half-life and chronic use of intoxicating. Um, okay, okay. So is it president according to schizophrenia spectrum disorder at least two of the following five symptoms. Delusion, hallucination, disorders, speech disorders, behavior negative symptoms. Negative symptoms. Okay, it's schizotypal personality disorder. Look at the schizotypal personality disorder. Okay, adjustment disorder with anxiety and admit the patient on over psychiatry unit. This is probably most of the personality disorder dramatic cluster. It's delusional disorder. And the last course that I made wrong, it's panic disorder. The shortness of breath, palpitation. Okay. Um, okay, so panic disorder. So panic disorder relatively common psychiatric disorder. Okay, this is the final psychiatry questions solved. Hope you enjoyed. Kind of boring, and I haven't explained that much, but you may enjoy. And tell me the name of the murderer of this video. Okay, bye bye, good night.